So for those of you who haven't met me, I'm Tara. I'm a PGY2, and Kat gave us a great overview earlier of how to handle pulmonary embolism in our general population. But today I'm going to be talking about our approach to pulmonary embolism in pregnancy. And before we start, I want to give a special thanks to the Small Talks team who helped me develop this presentation. So we're going to be going over when to consider VTE, venous thromboembolism, in pregnancy, which of the clinical decision-making tools that we have available to us is the best, and then briefly touching on diagnosis and management. So there is an increased risk of VTE in pregnancy, and this is due to the prothrombotic changes that occur. The incidence overall is around 2 per 1,000, but the risk does increase throughout pregnancy, as you can see by this little picture up here. As you progress, the risk increases, and then actually the risk is highest up to 12 weeks after delivery. And then it returns to baseline. The patient's like baseline around after 12 weeks. Some of the symptoms and signs to look out for are what we would look for in our general population, such as dyspnea, pleuritic chest pain, tachypnea, tachycardia, also signs or symptoms of DVT. And this can be a difficult diagnosis to make in pregnant patients. Because some of the physiologic changes that occur during pregnancy can mimic the symptoms of like pulmonary embolism. So, is the patient dyspneic because they have pulmonary embolism, or are they dyspneic because the gravid uterus is making it difficult for them to take a deep breath in? Is this ankle swelling that they're having now, consistent with how it's been during their pregnancy, or is it because they may have a DVT? So we can use our clinical decision-making tools to help us kind of risk stratify these patients. We have 3 that are available to us, and we'll review all of them. We're not going to go through them in depth, but I just want to make sure you guys are aware of them so you can save them in MD Calc and use them. So first is Wells, which is the one that I'm most used to using in our emergency department. The other one is the Geneva score. This differs from Wells in a couple of ways, but I think one of the major ways is that it gets rid of that subjective question about whether PE is your number 1 or most likely diagnosis. And then the last one we're going to take a look at is the years algorithm. And this one is special because it has a specific pregnancy adapted algorithm. So it asks if the patient is pregnant, and then if you say yes, that affects the D-dimer threshold. So if the patient does not meet any of the years criteria, then the threshold for the D-dimer is higher. It's greater than or equal to 1,000. But if 1 or more of the years criteria is fulfilled, then your D-dimer threshold is lower. Greater than or equal to 500 would be the cutoff. And we can't speak about D-dimer without mentioning FEU and DDU. So these are basically the measuring units that D-dimer can be reported in. When they were first developing the D-dimer testing, the creators had difficulty agreeing on which one to use. The DDU group used a known concentration of purified D-dimer for the measurements, while the FEU group used a known concentration of purified fibrinogen. So it's most important to know for us because there is a conversion between the two. So DDU times 2 equals FEU, or if you want to look at it the other way, DDU is usually half of FEU. And you can figure out what units your hospital uses by calling the lab. They should know whether you use FEU or DDU. And then you just have to keep in mind when the units are reported, you have to convert appropriately. So looking at some studies, I found some studies that looked at which of these clinical decision-making tools is best for use in the pregnant population. And this first one is a prospective study with a primary outcome of incidence of VTE at 3 months. And then in the secondary outcomes they looked at was the proportion of patients in whom CT pulmonary angiography was not indicated to safely rule out pulmonary embolism. So they started off with 494 patients that had a suspected PE and were managed according to the years algorithm. They divided them into a subgroup that met no years criteria and one that met 1 to 3 years criteria, and then were managed appropriately according to the years algorithm. They underwent D-dimers and then underwent imaging as necessary. But as you can see by this flow chart, there were quite a few protocol violations in almost every subgroup. Barring the protocol violations, though, there were 16 pulmonary embolisms that were confirmed. And in terms of events at follow-up, the only one that they had was a DVT, and one person was lost to follow-up, but otherwise there were no events detected at follow-up. So this led them to conclude that the years algorithm was able to safely rule out acute pulmonary embolism in pregnant patients in whom it was suspected. And they said that they were able to avoid CT pulmonary angiography in 32 to 65% of the patients. And they compared this to another study that was conducted on pregnant patients using the Geneva score. And in that study, 84% of the patients underwent either CT pulmonary angiography or VQ scan. So this was able to save patients who didn't need it radiation exposure. There was another study I found that looked at the Wells score and Geneva score for diagnosis of PE in pregnancy. This was a retrospective study. They looked at pregnant or postpartum patients with a suspected PE that received diagnostic imaging, either VQ or CT, over a 3-year period. And then they looked at the sensitivities and specificities. And this was after they looked at the data, this was the conclusion that they developed, the sensitivities and specificities for detection of PE in pregnant patients according to the Wells score and both the modified Geneva score really aren't that great. So based on these two studies that I came across, it looks like years is the best clinical decision-making tool to help risk stratify pregnant patients in whom pulmonary embolism is detected. So we've gone through our years, we've risk stratified our patients. Now we want to work them up to rule out PE. The first step you want to start with is a ultrasound. It's not invasive and there's no radiation exposure to the patient or the fetus. And then if it's positive, if you do find a DVT, then there's no need for any further diagnostics, as the management is similar. The patient needs to be anticoagulated. You can see from this diagram that on top, we have good flow through the vein, whereas on bottom, there is no flow through the vein. And then you can actually see something extending into the lumen, which would be consistent with a DVT. And then aside from assessing for DVT, we can also use the ultrasound to check for signs of right heart strain. If your patient is little unstable, like tachycardic, hypotensive, hypoxic. But let's say we do the compression ultrasound and it doesn't show any signs of DVT. We can't stop there. Our next step of imaging modalities would be either a CT angio or a VQ scan. And there are limitations to both of these, especially due to the physiologic changes during pregnancy. There's increase in plasma volume, there's increase in heart rate, there's increase in cardiac output, and this could potentially dilute contrast and also reduce vascular handling. But comparing the two, VQ versus CTA, there are some things to take into consideration. So there is a risk of nephropathy and thyroid dysfunction with the iodinated contrast that is used in the CT angio. And that risk is both to the mother and the fetus. And there's also a reported increased lifetime risk of maternal breast cancer in patients that undergo CT angio. Although I found some studies that said that this risk can be mitigated by using breast shielding. For the VQ scan, the interpretation can be based on the radiologist's level of experience and expertise. So interpreting a VQ scan is not as easy as looking for like a vascular filling defect in a CT angio like we see here. It's a little bit more complicated, and it does require an experienced radiologist. So if you're somewhere where maybe you only have access to a resident radiologist overnight, that could sway your decision between whether or not you want to get a CT angio or VQ scan. And then I found a systematic review and meta-analysis that looked at the diagnostic efficiency, the frequency of non-diagnostic results, and it also looked at maternal and fetal radiation exposure between CT angio and VQ scan. They weren't able to draw any hard conclusions because a lot of the studies that they looked at were low quality, but they did find that the false negative rate was 0% for both of the modalities. The rates of non-diagnostic results were similar between the two. And for both imaging modalities, the reported radiation exposure doses were below the acceptable threshold. So we found our PE. How do we manage these patients? Heparin is the way to go, either low molecular weight heparin or unfractionated heparin. You want to avoid warfarin and your DOACs. These cross the placenta and cause harm to the fetus. For our unstable patients, our patients with massive PEs, there are two options to consider. There's thrombolytic therapy, and there's percutaneous catheter and stenting. For thrombolytic therapy, I didn't really find any large studies that had been performed. There are concerns regarding the maternal effects and the effects on the placenta. And so the conclusion that a lot of major groups have is that it's best reserved for life and limb-threatening situations. For percutaneous catheter or like IR-directed thrombectomy, it seemed like the patients that undergo these procedures have pretty good outcomes, and there's low rates of adverse events. But it is important to keep in mind that there is a risk for a patient undergoing these kinds of therapies during the first trimester, because that's when the fetus is undergoing organogenesis, and these studies do require some radiation exposure. So, in order to recap, for our pregnant patients in whom we suspect PE, years is the best clinical decision-making tool to help risk stratify them. When we are looking at our D-dimer results, we have to remember the units that they're reported in and convert appropriately. And then in terms of diagnostic imaging, VQ scan versus CT angio, I think CT angio is the better way to go. I think that risk of breast cancer can be mitigated by shielding, but it's also the imaging modality that I myself am most comfortable interpreting. If you are between the two, it's also important to keep in mind the level of expertise of your radiologist. So you may want to give them a call. And you can also have a conversation with the patient. And lastly, for management, we're not using warfarin in these patients. And that's my presentation.